It gives me great honor and pleasure to introduce fellow alum, Lieutenant Governor Boyd Rutherford. You have his bio in your program, but I will briefly say that he is an accomplished attorney with a lifetime of experience in both the public and private sectors. He served as Associate Administrator for the United States General Services Administration, as Assistant Secretary of Administration for the United States Department of Agriculture, where he was confirmed by President George W. Bush. And prior to serving at the United States Department of Agriculture, Lieutenant Rutherford served as Secretary of the Maryland Department of General Services. In addition to his long list of public service activities, Lieutenant Governor Rutherford has extensive legal and business experience, including service in business and government law, information technology, sales, and small and minority business development. He holds a bachelor's degree in economics and political science from Howard University, and he received a master's degree in communications management and a law degree, both from the University of Southern California. I present to you Lieutenant Governor Boyd Rutherford.
Well, thank you. It's good to be back at Howard. This is the first time I've been on the stage. I've sat somewhere out here and usually way up there, but that was many, many years ago. So it's great to be here. I want to tell you a little bit about our challenge with opioid abuse and heroin crisis in Maryland and the approach that we've taken to try to address this concern. And I'll take it back about 4 years ago when the governor and I were running for office, and as we were traveling around the state, and you'd meet with local officials, be it the local law enforcement, the health professionals, local council or council members or commissioners, and we'd ask, what are the major challenges that you're facing at a local level? And we were hearing consistently that it was heroin was the problem. Now, we knew that heroin had been a problem in Baltimore. I mean, since I was a boy, it was a problem in Baltimore, but not at the levels that it is now. But we were also hearing in the small towns, the suburban communities, the high-end communities, out on Maryland's Eastern Shore, some of the little tiny towns like Hurlock. I don't know if anybody's been there. In Dorchester County, it probably has about 2,000 people max. That heroin was the big issue that they were all facing. We'd hear it from the sheriffs, and they'd also talk about the impact it was having on their jails, and they were some of the first that would say, we're not going to arrest our way out of this particular problem. You know, understanding from an economic standpoint, they don't want to see this revolving door of basically the same people whose real issue is their addiction, their sickness that they have, and not that the petty crime that they may be committing. And so the governor stated that once elected, he was going to convene a commission to explore solutions to this challenge. And so after the election, one of his first executive orders was to create the Heroin and Opioid Emergency Task Force, which he asked me to chair. We conducted regional summits around the state where we heard from the local health officials, local law enforcement, the treatment community, medical professionals, families, those who are in recovery, families that had lost family members due to this addiction. And we came out of that with a number of recommendations. Halfway through the process, we had some initial steps that we could take just using executive authority in terms of funding for treatment facilities, as well as some prevention areas. But we came up at the end with 33 recommendations that range from prevention to treatment to recovery and education to better coordination at the law enforcement side of it. And in the last 2 years, 2.5 years, we've been implementing a number of those recommendations, including putting forward prescriber limits, because the real surge in heroin use, as we often say, the new heroin users, have come off of prescription medications. So we tried to push through prescriber limits. We had a lot of difficulty with that. We wanted to follow what Massachusetts and some other states had done, where they said the initial prescription would be only 7 days. We got a lot of pushback, but we were able to at least get the CDC guidelines implemented in the state, as well as making our prescription drug monitoring program mandatory for all prescribers, as well as the dispensers, the pharmacists, that they must register now, and they have to inquire by next year, July of next year, that they are required to utilize the system as well. And we put more resources into the education aspects, starting at an earlier point in schools, to start talking about the challenges associated with opioids and with drugs and the addiction process. And, you know, the point that I make often is virtually every third grader can tell you how unhelpful tobacco products are, but they can't tell you how dangerous it is to take someone else's prescription medications. So you can start much earlier than, in many cases, waiting until high school health class to start talking about these things, or just talking about alcohol, but you can start much earlier. For those who remember history, there were opium wars in Southeast Asia at one point, or in China at one point. So you can incorporate a lot of this in additional classes, and that was one of our recommendations that we put forward. You know, on the prevention front, we feel that you really have to work to cut off that pipeline of new users. And so that's why my third grader analogy is so important. Some of the other initiatives were strengthening our Good Samaritan law, so that people who are with someone who may overdose don't feel as though they're going to have problems with law enforcement if they call to get assistance for that person. I mentioned the prescription drug monitoring. We made it more available, naloxone, which is the overdose reversing substance for families with individuals who were at risk, as well as first responders. Now, we found we did also have a standing order for naloxone so that anyone can get it going to a pharmacy. But we found there's kind of an unintended consequence of that as well, the free flowing of naloxone, where there's some individuals will sit there with a friend and will use heroin substances, and they will tell their friend, if I look like I'm about to go, you revive me. And so we have to be somewhat careful about it, but it is still a life-saving device. We've been working to make sure we collaborate with all of our local officials more so, but what we found is that despite a lot of our efforts, bringing attention to it, additional treatment and putting money into treatment, putting money into prevention efforts, that we were still seeing the overdose rate, fatality rate, continue to rise. Last year in Maryland, 2016, we had a little more than 1,200 individuals die from heroin overdoses. And 60% of that was fentanyl related. And with the increased usage of fentanyl and coming into the state, coming into the country in general, which is something that's 50 times more powerful than morphine, And then now we're seeing something called carfentanil, which is used for large animal tranquilizer, which is 100 times more powerful than heroin. We're seeing a real surge of overdoses. And so in response, the governor declared a state of emergency back in March, which allows for greater resources and coordination to take place with the local officials. And we decided to go in this route because when we had the unrest in Baltimore, we declared a state of emergency, but we didn't have anyone lose their lives during that time. When we had the floods in Ellicott City and Howard County, we had, unfortunately, 2 people lost their lives, and we declared a state of emergency. When we're having 1,200 people dying, about approximately 6 people a day dying in the state, it is an emergency. And so it allowed us to activate the emergency response network that's already in place from the state, working with the local officials, the emergency response people, and they work with their local health officials to coordinate efforts to try to address this issue. We opened what we call our Opioid Operational Command Center to help in this coordination, because a lot of the work, I should say the vast majority of the work, is at the ground level, is in the local counties and in the cities in our state. We allocated an additional $50 million over 5 years to fund prevention, treatment, as well as better law enforcement coordination. And then recently, combined with some federal funding, we awarded $22 million for these efforts as well, with the majority of that money going to the local jurisdictions to fight this challenge. Now, prevention and treatment are 2 essential components to going after this issue, but there is still a role for law enforcement, particularly as it relates to those who are trafficking and the trafficking organizations that are bringing this into our state. We make a distinction between those individuals who are financing their addiction by selling and those who are trafficking in these substances. And so last year, as part of our Justice Reinvestment Act, we included a Maryland RICO statute to go after the large criminal enterprises that are involved in a lot of the trade that takes place, the distributors of these poisons. And we've installed what we call heroin coordinators in the local law enforcement regions in the state that are working to make sure that they collect information and data that helps us to get a clear picture of where the drugs are coming in, what the hot spots are, what locale could be next in line. Some of the data that we receive, some parts of our state, particularly the northern counties, we know that the heroin is typically coming from Philadelphia coming into the area. If Philadelphia is having a surge of overdoses, more than likely those counties in the north are going to have a surge in overdoses as well. So that helps us. But we're pushing a lot of the policy, though, through our health department, because we see this as primarily a health issue, a public health issue. I mentioned making that distinction between the street level dealer who is financing their habit and the organizations. We also say, particularly in the justice reinvestment side, is we make that distinction between the person that we're upset with. They may have stolen our radio, they may have busted our window. We're really upset with them, but we're not afraid of them. And the person we're afraid of need to be taken off the street. That person, we need to get them treatment. And they're going to lose some of their liberty, but their main issue is getting them treatment. And so we've been working in the local jails and in the prison operations to make sure that we're able to get treatment, because the jail situation, the maximum time they're in a jail is 18 months. So in many cases, they're in jail for 3 months or 6 months. If we don't address their issue while they're there, they're going to be right back, because while they may physically get clean, they're sitting in their mind saying, I'm going to get high when I get out. And if they don't kill themselves, die, because they're trying to take the same amount of drugs that they took before they went in, they are back into that same cycle of dependency and then committing petty crimes to support that habit. But we've put a lot of effort into our overdose survivor outreach program, working with the local health departments to try to intervene, because we do get certain information, certain data where we know that an individual has had several overdoses and survived over a certain period of time. And so in some of the counties, we're able to get the health personnel to go back to their residents to at least offer them treatment services as an intervention. Because if that person has overdosed, let's say 4 times in the last 6 weeks, and they don't get help, they're going to overdose again, and eventually they're not going to be able to survive it. We've also instituted SBIRT, or screening, brief intervention, referral to treatment training for physicians in their practice, in their conversations with their patients, to get a better feel for whether that patient has a substance use disorder as well. So we know that this issue is widespread. It is not just a Maryland issue, it is a national issue, and it's going to require the assistance of all involved, from the federal, state, local level, the faith community, all of our community leaders, to get involved in this challenge. Because this is about not only bringing people back to productivity, but saving lives, as well as healing families and communities. So I appreciate this opportunity to be able to talk to you about some of the things we're doing in Maryland, and I think I have some time to take some questions as well, if there are any.
Hi, I'm Jonathan Pollack.
Hello. I didn't hear your name.
I'm Jonathan Pollack. I'm at the National Institute on Drug Abuse. And I'd just like ask you a question about types of treatment that the state of Maryland is providing or supporting in prisons and jails.
Yeah, what we've done in the local jails in particular is we've been providing Vivitrol for individuals who are close to being released, and in some of the local communities, that Vivitrol will continue for maybe another 2 to 3 doses afterwards. Vivitrol is a drug that reduces a little bit of the cravings. There's some debate about how much of the cravings, but basically, if the person falls off the wagon and they go back to taking an opiate, they're not going to feel the effects of it. And so the person who wants to get treatment, they will go into the Vivitrol program while they're still in jail. Likely the last 3 months that they're in jail, they'll get one shot a month, and then for 3 months after, they'll continue to get the shots while they're getting counseling as well.
So what's the transition afterwards?
After the 3 months,
Right.
they're still getting counseling. Vivitrol is very expensive. So unless it can be purchased through Medicaid, it's something that the state does not have the resources to continue other than counseling treatment at that point. No questions?
Good afternoon, Lieutenant
Oh,
Governor.
I didn't see it, sorry.
Good to see you again, sir. My question stems from a meeting, actually, which I had yesterday, or a group that I'm with, Health Solutions Research. We met with the Opioid Task Force in Hagerstown yesterday to present our product, which I've spoken to you a little bit about in past sessions. But my question specifically stems from a comment that was made by the captain of the police there in the county. And what he said very pointedly is that, well, it's great to hear about the things we're doing within the state of Maryland. He said, but, I have a problem in that my residents can travel 15 minutes outside, go to West Virginia, or end up in Delaware, and obviously there's very little coordination that's essentially seems to be done between the states, surrounding states. So if you would, could you kind of just 50,000-foot view of what the state of Maryland is doing in conjunction with our bordering states to ensure that we can
Yeah.
make a dent in this
Yeah,
issue?
that's a good question because we are a small state. And in some areas, like when you talk about Hagerstown, you are very, very close, probably the thinnest area of Maryland, where you're closest to West Virginia to the south and Pennsylvania to the north. We try to coordinate through linking our prescription drug monitoring program as best as we can to see what prescribers are doing in other states to make sure that people aren't doctor shopping or prescriber shopping. Through the federal supported Baltimore, Washington, HIDTA, high intensity drug trafficking area, that they do a lot more of the coordination from the state to state than what we're able to do. But it is a particular challenge in some areas that are very close to the borders to see what they're doing in terms of going across the border for more so prescription medications than the illicit drugs, the heroin and the fentanyl. It's more the prescription medications. So it is a challenge. Sir.
Hi, my name's Stanley Campbell. I came late, so please forgive me if you address this, but it's a piggyback on the previous gentleman's question. Would you support the establishment of a national prescription drug monitoring program to bridge those neighboring states?
I think it's probably something that we need to do. Now, we're starting to see that the doctors are prescribing, at least in Maryland, and I was in an event earlier today, and other states are seeing this too, that the doctors are prescribing less opioids. And I think it's the awareness that's being brought to the whole process and the addictive nature of the opioids. I don't think it would hurt to have a national program. The doctors, I can tell you in Maryland, had resisted making it mandatory. Is there a doctor in here? Any doctors here? Doctor, medical doctors? None? Well, they were, okay, at least one. Well, a lot of your colleagues were resisting that. And I think part of it was just how much additional work they thought it would be. And, you know, in terms of the monitoring that you'd have to inquire as well as put in information saying that you've prescribed opioids to this individual and query the system to see if somebody else has already provided that to this individual. So we'd run into some challenges going nationally from different groups, but I don't see a problem with it, if the systems can handle it. Ma'am. You.
Good afternoon. I am wanting to know, as a small business in the drug industry in terms of testing the drugs, if you have any special programs in Maryland
For drug testing?
Yes, any special drugs, any special programs for drug testing. We do all of the opioid. We do all of the drug testing.
Well, at a state level, we don't require it other than in certain positions, certain jobs. Some of it's federal. Our law enforcement requires it. It's federal. The transportation area is required. And then some private industries require drug testing as well. In terms of special programs, like in terms of financial assistance in that area, to my knowledge, we don't. I don't know of any offhand.
We're working with a facility or two in Baltimore for programs for...
You may want to pull the mic down a little bit to you.
Can you hear me now?
Yes.
Okay. We're working with a couple of facilities in Baltimore who have programs where the clients have to be tested, some of them twice a week.
Okay.
Because it's a treatment program.
Oh, yeah. The drug courts, in many cases, have that program. They require that. And we provided assistance to the drug courts. Now, how they administer it is really the local drug court, the local county or city decides on how they're going to handle that.
So,
But yeah, a number of the counties and Baltimore City have drug courts, and they require testing periodically for the person to stay in compliance with their requirements. For those who are not familiar with the drug court process, a person comes in, they've been arrested for usually a nonviolent offense. They can state that they're often questioned, but they can state that they have a dependency. There's a provision that allows them to get an assessment, where they get an assessment from a practitioner who can determine whether they really have a problem or they're looking for a way out. And if it's determined that they have a problem, a dependency problem, then they can agree to go through the drug court process, which allows them to have a certain amount of freedom, but they have to report. It's like parole, where they have to report, but they also have to go through treatment. And so in many cases, there's drug testing on that. Thank you.
Hello again. So this morning, there was a lot of conversation about how addicts obtain these drugs. And in spite of all the information that we've been hearing about physicians over-prescribing drugs, it turns out that that only represents 20% of the addicts, and that most of the drug abusers really get their medications, well, they begin by using family members' drugs or friends' drugs, and then they go on to heroin.
Right.
So I guess what my concern is that when we continue to say that it's because of physicians over-prescribing drugs, it sounds as though the people who are addicted are the people who get the drugs from the physicians.
Well, the surge in the heroin users, new heroin users, as we say, and this is over a period of time, have been people coming off prescription medications. And many of those folks started following a doctor's prescription, but at some point became dependent. And as the doctors became more aware, and as I mentioned before, our statistics are showing that doctors are prescribing less opiates than they were several years ago. As they've become more aware of this issue, they've been more conscious about the prescriptions and prescribing opioids. Some of this, you know, there are some that argue this started when it was a Hopkins doctor that, you know, came out with a best practice of one of the vital signs was pain. Well, pain is subjective. I might have a ache in my knee, which I sometimes do, that I might say is an 8, but my wife may have the same pain and says it's a 3. I might get opiates, at least the way it was. We think that doctors have backed off of that they're not as, you know, following just giving prescriptions and upping those prescriptions, giving a 30-day supply for something that really probably could do 7 to 10 days. Because there are people who believe you give them 30 days and they're supposed to take all 30 days. They think of it like an antibiotic, that you should take all your antibiotics. But the pain medications, you know, you take them to the point that you can go to over the counter or that you don't need it anymore. You know, you have knee surgery, it's going to hurt, you know, and so some of it is our society wanting immediate gratification, the microwave society, that we want it right away. We want the pain to end right away. And so I mean, you're right. I think the doctors understand it a lot better. That new surge has been prescription medications. And some of the people, when they weren't getting it from the doctors, would go to grandma's cabinet. That's why they had the drug take-back programs. I was at one in Howard County over the weekend, and we got 1,200 pounds of medications. Now, not all of them were opiates, but they were medications that people had in their, you know, cabinets that they just brought back. I mean, people were bringing bags of things, you know. So it is complicated, but there also is a traditional path to heroin use, too, that is still there and has been there and may even be growing to a certain extent. And that is marijuana or tobacco, marijuana, and alcohol. Those are the traditional path to heroin. The surge in recent years has also been adding the prescription medications. And so we need to also think about those traditional paths as well. Anything else? Okay, well, thank you. Appreciate the opportunity to talk to you a little bit about what we're trying to do.
Thank you so much.
Good to be back.
So we're going to give Lieutenant Governor a little gift from Howard, given that he is a son of Howard, and we're so honored that he is Lieutenant Governor of Maryland. Yes. So I'm going to give him an official pin of Howard University, something that he can wear proudly to remember where he came from.
Well, I'm gonna definitely wear this when I give the winter commencement at Morgan.
Where do you want it to
Let's see. Is there- yeah, why don't you do it? Thank you.
Please take a photo when you do that.
Oh, thank you. Thank you.
But I think there is also an important education campaign that we can do. As I think about the grandmother that I have worked with, whose grandson became addicted because she didn't realize that if she left her unused medication in the medicine cabinet, that he would come and use them. And then so when you start talking with people, so where I would start is talking with more people and finding out, well, the reason he was selling these, this medication is because there was no food in the home. So we have to, as Howard, we have a responsibility to understand what causes people to move to addiction to manage pain. Because there's the pain of poverty, there's the pain of domestic violence. So substances are often used to self-medicate because other systems have failed. So I agree with my colleagues. We start sort of repairing the systems that are broken out there, the structural problems in doing that. But I would start talking more with people to see what they are saying. And then build upon their narrative and add our expertise to that narrative. And then I think we can build a program that's more effective, culturally intelligent, culturally competent, all of those kind of things that we do best at Howard. We do better than anyone else out there. We know how to reach people where they are, and so that's where I would start.
Good afternoon. Hi, I'm Minnie Baylor Henry, another proud graduate of Howard University's College of Pharmacy. Yay. So this is session 4, Innovation and Enforcement Strategies. And what we're going to do is really try to drill down and examine sort of some of the issues that we heard earlier, but through a different lens. So we're going to be thinking about this through an enforcement and innovation lens. And then asking ourselves the question, have we gotten past the lock them up in the community, in certain communities? And so we really want to sort of have an honest dialogue about where we are and touch on some of the issues that have been mentioned during some of the earlier sessions around why are we in a state of emergency because we're talking about the opioids. But we were talking about cocaine and crack cocaine for many, many years, and we were not declaring a state of emergency. And we heard from one of the other experts that there's also an increase in cocaine utilization, but we're not sounding the alarm about that. And so these are some of the issues that we hope to discuss during our panel. And you have the bios in your program, so I'm going to trust that you'll read them. And I will introduce that on my far left, which would be your right, is Tom O'Donnell, who's Senior Vice President, Government Affairs and Public Policy, National Association of Chain Drug Stores. Next to Tom is Shane Dana, who's a special agent with the Federal Bureau of Investigation, also known as the FBI. Next to Shane is Joseph L. Wright, who's an associate judge, District Court of Maryland, Prince George's County. And next to Joe is General John Morgan, who's the Chief Operating Officer with Eagle Force Associates, and he'll tell you more about Eagle Force Associates. And so we're going to do a bit of a hybrid model. So we have, some of our speakers have a few slides, and others will offer some opening comments. And so with that, I would ask that we turn it over to Tom.
Thank you, everybody, and I really appreciate the invitation from Howard University to come here and talk about this pressing crisis, and especially Dr. Etienne for so much work that goes into a forum like this, so a big thanks to him. I think a theme you'll hear from me, and hopefully through this panel, is going to be about collaboration. Chain pharmacists work day in and day out on this problem, and we're one part of the healthcare provider community, but between law enforcement, local communities, a number of people here, we all play a role, and I hope this just helps to, continue that dialogue and come up with solutions. But I think there's really three things here. I'll be successful, I convey them to you. One is just talking about our commitment to combating this drug abuse and diversion, but also at the same time providing really top-notch patient care. And talking to the pharmacy students here, I know they understand that. But the second part of that would be also the tensions involved in that, and the fact that there are judgments that pharmacists are going to have to make every day to decide what's a legitimate prescription. So that would be one other issue. I think third is to talk about a portfolio here of legislative regulatory tools that pharmacists can use, but other practitioners that will help us address this problem. And I think especially with the Christie Commission report yesterday, a lot of things with pharmacy, obviously across the full spectrum of solutions here and different players in finding solutions here. But I want to talk about those issues. So starting off here, it's a complex problem requiring, as I say, a holistic approach. Pharmacists work day in and day out. There's training. We've provided red flags documents with other stakeholders that help identify at the point of service, figuring out if a patient might have a problem or maybe at risk for diversion. There's also in-house security and tracking systems that we use daily to try to work on this. But we try to make sure that prescriptions are counted each part of the way here. But again, coming back to it, there's so much. Pharmacists have one point of care here. There's other points of care, so it really begs that we have to have a collaborative approach in the dialogue today. The one thing I want to point out that's very specific, well, it's to prescribers and to pharmacists, is a concept called corresponding responsibility. And not everybody, outside the pharmacy community knows this, but basically just read this. According to the DEA, while prescribing clinicians are responsible for proper prescribing, dispensing of controlled substances, a corresponding responsibility also rests with pharmacists to fill the prescription. I would tell you that the best way I could characterize this is every day a pharmacist faces a moment of truth, whether to fill a prescription or not. And, you try to avoid drug diversion, you realize an abuse, you realize that also you've got somebody who could have legitimate pain issues. So that makes things very tough, especially with pharmacy being one of the most highly regulated professions in the country. You're working at the State Board of Pharmacy, our law enforcement agencies, other healthcare providers. It's a very strict regulatory regimen. We try to do our best. So I think to assist in that role, we suggest some legislative and regulatory tools. The first one is to limit initial opioid prescriptions for treatment of acute pain. I think you had Express Scripts here before, and Sure Scripts. They probably talked a bit about this, but we want to limit legislation, federal and state level, that would limit that initial opioid prescription for acute pain to 7 days with appropriate exemptions for chronic care and oncology and hospice patients. But, the problem here is CDC's, their analysis is showing it, that initial opioid prescription can really lead to problems. So we want to reduce that prescription. And, at this point, from 2006, we've actually seen an increase in the number of days supply for a single opioid prescription in somebody's medicine cabinet. It's gone from 13.3 days to 18.1 days. We want to try to lower that as much as possible. So this legislation, which actually in some form or the other has been now adopted by 20 states, I think is crucial to that. The next thing would be e-prescribing and the benefits there of eliminating abuse or fraud with written prescriptions, getting more efficiency. So poorly written prescriptions, you're actually helping people in that now a pharmacist will see exactly what fields are in that prescription, will be able to give proper care. And the main thing, security, second-party authentication the DEA requires. So these are secure scripts. I'd also say that we're supporting legislation in Capitol Hill by Congressman Clark and Congressman Mullins that would make it mandatory in Medicare Part D that any Schedule 2 through 5 prescriptions are done electronically. So I think that's a big part of the key here. Also, I know we've probably heard of, on PDMPs. We're looking for a national solution. The Christie Commission yesterday called for that. End of the day, if we can base that on electronic prescribing systems, we're hopeful we can get the real-time type of workflow analysis for pharmacists so they can pick up those problems very quickly. Lastly, I talk about take back and disposal. A lot of pharmacies now are doing different, whether it's kiosks, mail-back programs, parking lot events, but it's essential for people to have a place to bring these substances back to. We're also suggesting that we, at a patient's request for an opioid prescription, we provide a mail-back envelope. So giving those patients who may be in rural areas or places with access problems the ability to return these unused opioids. And I'll just do this very quickly. A number of other things that we're really suggesting to policymakers, mandatory prescriber and patient education. The FDA REMS program is really going down a great path on that, and we support that. Promoting more access to naloxone, whether it's statewide protocols, making that naloxone isn't patient-specific prescription, collaborative practice agreements. The more we can do that in the states, it's better for pharmacists to have those tools. Targeting illegitimate drug sellers, whether it's online, illegal online pharmacies, trying to work with web service companies, financial companies to cut those companies out that are providing that unfortunate, international illegitimate pharmacies, and also just the onslaught now of synthetic opioids, the synthetic fentanyls that cost 20,000 deaths last year, working with law enforcement on that. And then finally, shutting down rogue pain clinics. I think it's essential. You remember, obviously, Florida had a huge problem. We do support not allowing prescribers to dispense at pain clinics. So a lot of different concepts there. I just wanted to say that, we look forward to working with everybody in the supply chain and the shareholder community to address this problem. I thank Howard because I think this, again, helps with a collaborative approach with us, industry, and others, and I just thank you for your time.
Shane?
No slides, ladies and gentlemen. I just have a few brief comments. I want to offer my perspective as a frontline special agent working on the opiate epidemic. First off, I believe it's extremely important to have a very diverse perspective when understanding the opioid crisis, and I applaud Howard University for bringing so many different viewpoints together today to talk about it. We cannot understand the opiate crisis through the eyes of law enforcement alone. We cannot understand it through the eyes of public health alone. We need to engage other partners, to include the economists, the pharmacist, the social scientist, the social worker, the treatment professional, of course, and the faith community. Every discipline has a stake, but there's another voice that we must listen to, and that's the victims of the crisis. Their voices matter and can give us guidance in terms of finding effective strategies. Look, I've been doing this for about 14 years, working cases on opiates, and I have talked to hundreds of persons who are affected. And when I'm in those conversations with them, I always feel compelled to ask them, hey, what went wrong? What happened at that decisive moment? And the responses I get back can be grouped into 3 categories. First, I had no idea. I had no idea that substance would do that. I had no idea it would get me addicted. There is an information gap out there, and people don't understand the addictive potential of the opiate. We need to do a better job at filling that information gap. The other comments that I hear fall into a category that I consider, it was like filling a hole. And let's face it, we all have something we struggle with. That hole can be a manifestation of, say, trauma or a difficult family life. Maybe it's financial problems, self-image, self-esteem issues. There's so many things that can create a hole, but it's how we address that hole, how we fill it, that matters greatly. And when someone turns to the opioid to fill that hole, the results are catastrophic. And I look forward to the future panels after ours to discuss that topic in general. And then finally, my friend gave it to me. Ladies and gentlemen, peer pressure is a real thing. If you do not believe it, talk to me later. I will talk about some of the evidence that I have uncovered during my investigations that have exposed me to a true understanding of what peer pressure can look like. It's amazing. Young people, they might be awash in a morally relative environment where drug use is the norm, maybe even within their own family. So we need to equip young people with strategies that they can employ to extricate themselves out of situations where they find themselves at a crossroads of desire, temptation, and opportunity. I have much to say on the topic and lots of thoughts about strategies and the ways ahead, but hopefully we can get into that in discussion. And I look forward to also learning from the audience. Thank you.
Jay?
It's a pleasure to be here at Howard University. I'm a proud graduate of the school, the institution, so thank you for being here. Thank you, Dr. Ntien, for putting together this program. It's a very needed discussion. The opioid crisis has hit, and all of my research has shown that about 2 million people died. 2 million people are affected with this disorder. 33,000 Americans died because of this disorder. Marylanders, we had about 2,000 died last year, more than 2,000, which was a 66% increase from the year before. Everyone sees the tidal wave. I can't even say coming, it is here. And we as the courts are trying to establish what to do and how can we help combat the problem. I'm here because I am the presiding judge of District Court of the Drug Court here in Prince George's County. And as drug court, many of you may know, drug courts are alternative sentencing courts. Drug courts, and the alternative is jail. Instead of locking up, trying to incarcerate our way out of problems that occur, be it trespasses, malicious destruction of properties, loitering, minor thefts, instead of trying to lock our way out of it, incarcerate our way out of it, we've recognized that that is inhumane, ineffective in terms of cost, and just simply doesn't work. So drug courts came about throughout America, really in the last 20 years, which isn't that really far when you look in terms of the criminal justice system. But drug courts now exist in every state in the union. But are we doing enough is really the question people ask. whenever we're faced with different crises, and the current crisis is this opioid crisis, we have to look to whether we have enough resources in order to assist. Drug court, we have helped numerous people, but it comes down to a partnership between the court system, the judges, the prosecutors, who must wear a slightly different hat than what they're used to dealing with, defense attorneys, Department of Health, social workers, probation agents. This is a total team disciplinary approach to really trying to have a drug treatment program within the court system. But the numbers have borne out. It has been the most studied program in criminal justice area, drug courts. For every dollar invested in a drug court, clearly more than $2, $3, $4 are returned to the community. You invest $1 in drug court, in between $2, $4, up to $12 is invested. And we go up to $12 if you look at the cost of re-victimization, incarceration, recidivism. Drug courts work. But we need to do more, and we need to continue to invest in them. I will be glad to take questions. It's a pleasure to be here today. Thank you very much.
Okay. First of all, thank you to Howard University and School of Pharmacy. It is indeed a pleasure to be here today to talk about this challenge that faces each and every one of us here in America, and that being the opioid crisis. My name is John Morgan, and I am the Chief Operating Officer at Eagle Force Associates. We are a predictive analytics big data company, and that's kind of where I want to take these remarks before we start the panel discussion, because from our perspective as technologists and operators, this is about getting out in front of the problem. It's about dealing with how do you leverage technology, algorithms, predictive analytics to then deal with the emerging challenges that we face today in healthcare. But before I go down that road, let me take you on a little bit of a path about me and how we kind of get here to deal with this challenge. I spent 35 years in the United States Army, and in my last job was the commander of the Allied Land Forces for the North Atlantic Treaty Organization and NATO. So 28 different nations with 28 different command and control systems, all that don't routinely talk to one another. That was part of a big challenge within the alliance. So the question is how do you create an interoperable system where you can share and pass information, data, voice, video, text, information for a warfighter to be able to conduct what he does, yet be able to leverage that same capability now in the space of healthcare. Well, Eagle Force is an innovative company that is in the midst of doing just that exactly, and as a matter of fact, we have created the tools that you've heard some of our speakers already talk to help get out in front of this opioid problem. We've created a tracking and monitoring system, and you probably heard even in the previous segment talking about a national ability to track opioid prescriptions nationally. One of the challenges that we face today is that the tool sets that are used to do that are done at the state level in various ways. Each state has its own prescription drug monitoring program. They are extremely decentralized, and unless you have the coordinating agreements between states, they don't routinely talk to each other, very much like that international problem that I dealt with while I was wearing a uniform. And so, in addition to not having the interoperability to communicate on opioid prescriptions, transactions, and patient needs, you also get into degrees of latency. Many of the prescription drug monitoring systems talk about the ability to do prescription tracking in real time. Well, real time may be a function of every 24 hours we upload the information. Perhaps every 7 days we upload the information. And in some cases it doesn't get uploaded for maybe a 2-week period. Well, you have prescribers and pharmacists that are out there today dealing with this challenge as to whether or not they need to fill a prescription based upon latent data, based upon prescription drug monitoring programs, although very, very good, don't create that degree of interoperableness to be able to help get out in front of the challenge of this problem. Additionally, as we continue to move, you'll find that although there are electronic ways of being able to pass prescriptions, there are still cash prescriptions or people looking to fill their opioid prescription and pay for it by cash. Well, the ability to have a national opioid monitoring and tracking system that also compensates and allows you to see that transaction even though it is paid for at the counter pharmacy in cash. And then we talk about integration. What we've been able to do and build is to deploy today a real-time opioid monitoring and tracking system that touches every point-of-sale pharmacy in the United States in real time. We have deployed this today to be able to do coupon co-payment edits. Today, our major clients are in the area of large pharmacy, coupon and co-payment edits. And the ability to then, at the point-of-sale pharmacy, be able to determine whether or not you, as the patient, are eligible for a particular medication. Well, imagine being able to now do that for opioid prescriptions in real time, in front of the problem, before the patient actually leaves the pharmacy, be able to determine whether or not there's an alert. Let's take the Virginia, Maryland, Washington, D.C. area. And with a cash prescription, my ability to then, within probably an hour, go to a Rite Aid in Virginia, a CVS in Maryland, travel to D.C. and go to a Costco and fill that prescription. Well, the ability with unique, innovative ways in technology to be able to identify the patient, link that patient to a particular prescription, and the ability to see you wherever you might be, whether it is in Virginia, Maryland, or Washington, D.C. I like to use, as an example, the issue of Prince, who had an opioid prescription filled in Minnesota, traveled to Atlanta, had another opioid prescription potentially filled in Atlanta, with a national opioid system that has the ability to leverage data from multiple prescription drug monitoring systems. And oh, by the way, the last time I looked at a map, Minnesota and Georgia are nowhere close to one another to be able to share information with respect to prescriptions. But the unique, innovative ways in which technology has come forward allows that ability to see across state lines, to be able to do interstate and intrastate adjudication in real time at the point of sale of the pharmacy. Why is it important to get out front? If I could have the next slide. Is it going to pop up? Oh, I got the pusher. Got to be smarter than the average bear here, right? Okay. Oops. Here we go. Let's take the state of Virginia. We recently briefed key leaders from the state of Virginia, chief of staff of the state, and just to this date alone, they've had over 1,400 deaths due to opioid overdose in the state of Virginia alone. Was on Capitol Hill this past week in the Energy and Commerce Committee, of which a representative from the Center of Disease Control indicated that for every opioid death, there are at least another 60 people that are addicted to opioid medications. So if you extrapolate that out forward, think about the total number of people that are actually under the burden and potentially addicted to opioids that will potentially become a casualty. This is about getting out in front, the ability to see at the point-of-sale pharmacy to be able to say, no, that individual is potentially an abuser of opioid, or if he's a nefarious actor, he or she is a nefarious actor, the ability to intercede and stop the transaction before it occurs. So with 84,000 potentially addicted folks, if we move on to the next slide. Okay. I think I'm missing a slide. But somewhere in there, we talked about the number of facilities that the state of Virginia has to deal with 84,000 potential addicted individuals. With 275 facilities that the state has, and if you average that out to about 15 to 30 beds per facility, you quickly find out that you do not have the capacity to get at the total number of folks that are potentially addicted based upon the CDC's numbers. So what this is about providing interoperable analytic solutions to providers and to pharmacists in real time to help stop this scourge of opioid addiction and abuse before individuals leave with a medication in hand. We are creating unique ways to be able to do that, and I believe that innovation, as what's already been talked about, to help solve this problem and help alleviate the problem are some of the tool sets that can be provided to pharmacists and providers to help scourge this problem in our immediate lifetime. So with that, I look forward to your questions and the opportunity to engage with the panel. Thank you.
So we want this to be a conversation and not just talking heads. So you don't need to wait until there's a Q&A period. Come to the mic and we'll engage as we go along. We'll start the conversation, but I encourage you to come up and be a part of it. So I'm going to start with you, General, because I love this whole idea of big data and the predictive power of big data. And I'm wondering, Tom, if there was something that the General said that resonated with you as it relates to your members. I mean, think about the connectivity that could occur with all of the chain drugstores using these predictive powers that the General talked about, and wondering sort of, is something like that on the horizon?
Just want to make sure I heard the question correctly, but you're talking about some of the solutions the General is offering, how they might apply to chain pharmacy. Is that correct?
I think so, definitely.
Yeah, so I think, as you saw, there's a number of solutions, whether it's
Tom,
e-prescribing, whether it's e-prescribing, whether it's PDMPs, that really are the future to make sure that pharmacists have that real-time data at their fingertips to be able to make those informed decisions. And I think we're getting to the point now with a lot of these workflow systems that can help, put flags for pharmacists to identify people who are, suspect of possible abuse, maybe showing signs. There's, of course, the, different signs that pharmacists pick up themselves, but you know how busy a pharmacy is, how many prescriptions you're filling a day. So I would just say a lot of the solutions the General was talking about, I think there's things we should have more of a conversation about. We do support a national PDMP construct, and there's still a lot of details to be worked out because there's obviously now 49 systems, about to be 50 now. Missouri is going to be, finally put their own system up. They've got a number of county systems. We're getting more and more use of e-prescribing. There's now 97% of pharmacies across the country actually are enabled to e-prescribe. So I think it's the start, and looking at these other possible systems, there's some real potential there.
It's great to hear you say that, because what we are seeing today is the ability to then take the data from disparate, in this particular case, prescription drug monitoring programs, and then be able to do billions of calculations in real time. And what I mean by real time is within 12 to 20 milliseconds. And again, at the point of sale, so the individual is standing in front of the pharmacist, and you have unique patient profile, that the ability to then track the individual and then track the prescription, be able to tie that back to the provider, be able to tie that back in real time to the pharmacy. These are the kinds of tools that, at least from my uniform wearing days, I would describe as decision support tools for pharmacists and providers. And they are here today. They have been used in other segments and other industries. Worked with them for a number of years while in service. Now there are unique ways to then be able to bring that to an industry that can look at this not only clinically, from a clinical perspective, but then when you're thinking about it in terms of regulatory requirements and being able to go after the bad actors, the ability to then roll up data so that law enforcement agencies across the nation can have a real-time look at where the trouble spots are across the nation leveraging big data.
So are you going to connect Shane into your database so that the FBI has the information?
I would love to connect as many folks as we possibly could. This is not a singular problem. It's not just for clinicians. This is what I would describe as a whole of government problem. It requires the medical community. It requires the economic community, commerce. It requires law enforcement to deal with this in a truly holistic way to help defeat this problem so that we don't have folks on the back end of the problem, and the back end, unfortunately, are deaths. And it's about getting out in front of it so that we reduce those deaths across the nation.
Thank you. I'll be back to you, Shane. Yes, ma'am.
Hello, good afternoon. So I'm going to try not to be too philosophical. I'm Tamara McCann, College of Pharmacy. When I first saw the title, or even when we think about the interface of enforcement and drug addiction, I think it's usually inappropriate or an archaic way of managing substance abuse through enforcement. But I was very encouraged by some of the things that I heard today in terms of solutions, including the drug court. I had never heard of that before. But what I wanted to talk about or ask the question is, how do we foster a relationship between healthcare professionals and law enforcement? Because especially as a pharmacist or as a prescriber, when a person is in front of you, whether it's someone that's trying to get a whole bunch of fentanyl to sell it or someone that is feeding their addiction, we really sometimes don't know what to do. Or we, especially as a pharmacist with all the pharmacy robberies, what can we do systemically to kind of bridge the gap between the healthcare professionals and law enforcement to really help patients get better?
If I could grab that. And I'm just going to offer an example as one way that I've seen that gap bridged, and I'll reference Anne Arundel County as an example. And other counties are taking up this model as well. And that's the advent of the crisis intervention team. And it's, I think it's a brilliant best practice that's being employed. And it's essentially making a mental health provider part of that first responder unit. So where there is a call, for service that incorporates the need for a mental health professional or someone that's going to be versed in the resources available for drug treatment, it's going to be difficult to get every law enforcement officer on that page, but within that dispatch, there's going to be ready to go with a radio, a mental health specialist that can show up on scene at that incident and help direct people in the appropriate direction. Other counties, their narcotics officers are carrying a card. So when they come in contact with someone with a substance use disorder, hey, here's some resources for you to reach out to. So in addition, there's training and education, and law enforcement's ramping up. But I do support the crisis intervention team model.
I'm going to answer it also two different ways. Did you say pharmacy robberies? Did you say that? I did. I have seen cases where the pharmacist had to come to court and said, I'm being threatened because this person said, give me more of what I want or else. I shouldn't have been surprised, but I was really surprised that it does affect pharmacists in that type of way as well. They're getting literally threatened and have to go out and obtain protective orders, peace orders, file criminal charges, trespass orders against people who want what they want. That's number one. Number two, I've talked about the team approach. It's not the traditional model, what most people are used to in terms of criminal court, where a prosecutor tries to send you to jail, a defense attorney keeps you out of jail at no cost, a judge makes the determination. We're all in this together, including probation and social workers. I would love to have the pharmacists on board as well, because this is how it plays out. The young man is in drug court. He's self-admitted, I have a problem, I've had a problem for a long time. And then all of a sudden, he's testing positive, because in drug court, you have to drug test pretty much nationally a certain number of times a week. For me, it's twice a week you have to drug test. And all of a sudden, positive for opioids. Oh, well, the pharmacist prescribed, my doctor prescribed for me this specific medication, Oxycontin, whatever it is, because of the pain in my leg. And so we tell them, did you tell the pharmacist you're in drug court? Have you told your doctor you're in drug court? Oh, they know. And I see you all shaking your head, no, they don't know. HIPAA is out there. But we've asked some of our clients to waive some of their rights so we can get real information from doctors and pharmacists, because we would love to have them on board as well as a part of the team, so we can understand, is there another alternative to tramadol? Is there another alternative to the narcotics you're actually subscribing to the personnel in drug court? And most doctors and pharmacists will say, yes, there is. But he or she never told me that that's what was needed. So I would love to have it on board, and we have to figure out a way beside the client saying, yes, you can talk to my pharmacist. Next time I'm there, I'm going to have my pharmacist call you, Judge Wright. That's where we are, and that's old school thinking. We do need something new.
Thank you. Yes, ma'am.
Hi, my name's Naomi Seiler. I teach health law and policy over at GW. I have another question about drug courts and just the intersection between public health and the criminal justice system. And I know that drug courts vary widely, but my understanding is that there have also been some concerns about them. So, for example, the fact that some people may still leave with a criminal record or an arrest record, the fact that sometimes people who relapse wind up getting a criminal sentence anyway, even though, as we've discussed, this is a chronic disease and many people do relapse, or the fact that people sometimes wind up, upon relapsing, with a longer sentence than they would have if they'd gone into the court in the first place. I just wanted to know if you could speak to some of those concerns, and also perhaps to pre-booking diversion programs as an alternative approach.
The last phrase you said,
pre-booking, or so programs in which, and I don't know if the FBI gentleman is familiar with these, but such as LEAD in Seattle, where an officer has the ability, rather than arresting someone to begin with, to bring them in to a treatment program that's aligned with the law enforcement agencies, so that there isn't an engagement of the court system at all.
I think I heard most of the question. We're having a hard time hearing because of the microphone situation. Drug courts do vary wildly throughout the nation. In Maryland, anyone can actually refer someone to a drug court, at least in Prince George's County and throughout Maryland. So if a police officer understands this person I've just arrested for the third time at the pawn shop, pawning your weed whacker, this person has a drug problem, they can refer to drug court. When the person's arrested by a police officer who doesn't refer them to drug court, the lawyer representing them can say, you know what, this person may need drug court. The prosecutor, who may end up in a discussion with this person over a plea and realize, you know what, I see your record and you have 14 thefts, 3 trespass, 5 loiterings. Do you have a drug problem, sir? Yes. The prosecutor can refer, or the judge, when the person stands in front of you and says, I've been convicted 18 times, 14 times, arrested 74 times. I know I have a problem. The judge can refer them to drug court. You can enter drug court post-arrest, pre-plea, after plea, condition for probation, all those ways. Are drug courts perfect? No. Is the criminal justice system perfect? I think most people say no. Is human elements, errors are made, so on and so forth, but drug courts have high recidivism rates. When you're dealing with someone who has been on drugs since they were 14 or 12 or 18 and they're now 48 years old, we're not miracle workers, but we're trying the best we can and trying to at least make sure this time we get you the help you need. Some people have been in and out the system and never obtained the help. Some people they did go to a drug treatment program in the early 90s, then they completed another one in the 2000s, and they're still struggling with this because we look at it as almost like a mental health issue. It's a public policy issue, much like something that's hard to kick. Sometimes you are on the wagon for 20 years, 10 years, or 6 months, and you do revert back to your old ways. Sentencing varies wildly. Generally, in most drug courts around the nation, if you're in the drug court, your charges are extraordinarily diminished in terms of what sentence you could receive. For us, that falls through as well. Sometimes the charges are dismissed outright, but it's according to where you are. I think I answered some or most of your questions. I think I did. Yes.
Thank you. So before I transition over to this side, Tom, I was wondering about kind of the pulse of the pharmacist. So how are your pharmacists that are working in the stores that are part of your association, how are they feeling today about the important role of the pharmacist in helping to overcome this epidemic that we have with opioids?
Well, I can talk broadly to it. Just one, it's something I think pharmacists take very seriously. I mean, it's a sacred trust about trying to help people through a problem like this. So, public opinion surveys show that pharmacists are the #2 most trusted healthcare professional in the country, and people come to them for their medication decisions. So I think one is we always try to help our patients through these questions, especially when it starts to involve opioids. I think the pharmacy community in general is really embracing their role right now, and I'm seeing a lot of leadership with different companies trying to get out there, whether it's on take-back programs, on specific patient counseling, educational services. So, I think we've seen the pendulum swing a little bit. Before, there were the days when we had pain was the fifth vital sign, right? And now we're seeing with the issues, epidemic we've had, obviously we're having to become even more attuned to the potential problems that our patients are having. So I think you're seeing it with the pharmacies themselves, how they're reacting, but also an individual pharmacist. I would mention one thing which I think it's a start, but since 2013, there's been a 15% decrease in the actual number of opioids prescribed, actual reduction in the number dispensed. So, that's a reflection on prescribers taking this more seriously, but pharmacists, I think, working through red flags, working through your own professional education, it's made a difference. We have a lot more to do, but it's made a difference.
Thank you. Right.
My name is Fred Mumford, a 1967 graduate of the College of Pharmacy here at Howard University. And I just wanted to stand to say that being a pharmacist, practicing pharmacist all these years, seen a lot of changes, but we still must realize that pharmacists must be allowed to be more proactive, and particularly with the chain drugstores and being able to do patient counseling. I'm amazed now to say when we give out those opioid prescriptions, people don't understand the side effects of what's happening, even though it's on the labeling. But again, I want to say that once you treat the immediate pain, then we still must be able to address the emotional flaws that our patients have. And lastly, I want to say, because of what my profession is now in terms of being a Baptist minister, we must empower the spiritual wellness understanding, because you're not going to have to worry about taking opioids if you know in yourself who you are and what kind of person that you're raised to be. So it has to be a combination of all three. We won't be able to medicate ourselves out of this crisis. That's all I wanted to say.
Thank you, Fred. Yes, ma'am.
Good afternoon. Thank you. With the more wide availability of Narcan to first responders, I feel that first responders have a unique opportunity to be able to help transition patients who are suffering from opioid use disorder to services. So I was just wondering, as my question, how often do first responders connect patients to services after they've revived them with Narcan? Could you?
How often do first responders?
How often do first responders connect people who they've revived with Narcan to services, for example, like opioid use disorder treatment?
Okay, got it. So Joe, is that something for you or for Shane? Okay.
Sure. I think I understand the question. You're asking how often do first responders come in contact with the same?
How often do first responders connect those that they revive with treatment programs? So the first responders administer the immediate care, but then do they take it to the next step where they say, and these are the programs that are available in your community to
Right.
help you so that they don't have to come back for another response?
Yeah, all right, I'm good. My, law
Okay.
enforcement, military hearing is not
Oh,
great. So,
sorry.
It's really a good question. It's very tricky, right? So, if you look at the evolution of what first responders are having to deal with, it's becoming more and more complex. And I'll use an example where I'm thinking of a county in particular. Their first responders come in contact with numerous people who need to be revived. And they bring someone out of an overdose using Narcan, and they administer a full dose. And if you understand how that works, that person is seemingly okay. Sometimes they're agitated that you took away the high, or now they have to, go through a withdrawal, and that person is lucid, clear, and conscious, and can refuse treatment at that point. That is a pickle for first responders. Can they take that person, force them into that ambulance, and say you're absolutely going to the hospital where you're gonna see someone? Not at that point. So, their hands are tied in those circumstances. I will tell you, most counties are doing a great job getting their first responders up the curve on how to bring someone back and make resources available. But like I said, best practices are emerging to adjust to those tactics. The CIT teams that I talked about. You just brought someone out, they don't want to get on the bus, but you have a CIT member right there that can pick up that dialogue. So it's tough.
So do you work with the local programs like the drug court? Do you ever refer to someone that you're dealing with through an arrest to drug court? Yeah, yeah. You should.
You know what? I have not been involved with drug court. Again, as a federal agent, I understand there's programs at the federal level, but once someone goes into custody, that's a probation and parole issue. That's a Bureau of Prisons issue. It's not something that FBI agents typically get involved with. And I talk to our local counterparts, and I hear mixed reviews. Some drug courts are fantastic. Some some might not be as effective. But I think a good drug court is another one of those best practices that we have to look at the models that are working and bring them to bear.
Thank you. Yes, sir.
I'd like to add to
yes,
that if
please.
I could. The recurring thing that you keep hearing, whether it's in the court system or dealing with first responders, and I have to be careful about when I say this as a guy that used to work in the government, and unique patient identification. There will be some that will look at that and say, well, is that Big Brother or anybody else that is into my business? But it really gets down to identifying those that are at risk. And there are unique technologies, patents, algorithms For example, the organization that I'm with did the background behind TSA passenger screening for secure flight. The ability to get on an aircraft anywhere in the United States and identify me as John Morgan. The ability to identify and then make available to prescribers, in certain cases, to the law enforcement, if it's nefarious folks that we are pursuing. But it allows us to have unique tool sets across the whole of government, again, because it's a holistic approach, that leveraging technology and the ability to do unique identification of individuals that are at risk for opioids, and to interdict early on in the process to leverage capabilities that have come out underneath the Comprehensive Addiction and Recovery Act, which is legislation that the Attorney General can use to help combat the opioid problem from a standpoint of going after bad actors, but then also putting education pieces in place to make sure that we're informing folks that do have an addiction and to give them the care that they need to help try and get them off the opioid medication. So again, leveraging tools and technology, whole of government solutions, I think is part and parcel to this and can go a long way to helping to alleviate some of the problem.
So your database then is comprised of tracking opioids, or has the capability of tracking it because of transactions. And I'm wondering whether you have the capability of tracking other controlled substances or street drugs, so to speak, so that you have something that's much more comprehensive, so that you can then, in a predictive fashion, see that there's a rise in crack cocaine, but it's flying under the radar screen because it's not being tracked through these big data sources.
Well, the capabilities that we're working with today certainly get at the classes of opioid medication and benzoids that compound those opioids. A little bit tougher to do when you get into the street drug, and that is the big challenge. Even if you're able to curb the prescription, it's running folks then to other sources of supply. Again, a holistic approach then perhaps where law enforcement is looking at the street piece of this, while we also look collectively leveraging technology to get at the prescribed medication that has become a challenge and for people who now are addicted. But the opportunities are there. And the other piece I'd like to come back to is when you start looking at unique patient profiling for prescriber to get out in front, the opportunity to leverage algorithms and ontologies that get at the very nature of disease. Disease manifests itself differently in each and every one of us. And so Morgan might be more susceptible to a particular type of drug, and so therefore, if a prescriber knows that up front, perhaps those are part of the decision-making apparatus that we get into out front of the problem in terms of prescribing, that we don't have an individual go down the wrong path with taking a medication that can potentially lead to addiction.
Yes, sir. Good afternoon. I'm retired Judge Arthur Burnett, one of the creators of the drug court system at the very beginning. And I'm one of the three principal founders and CEO of the National African American Drug Policy Coalition. And I have three questions. Working with Wesley Clark, who was then director of the Center for Drug Treatment, he asked me to focus on the issue of senior citizens who run out of money or insurance coverage, switching to opiates, and I've had defendants before me, 67, 68 years of age. What focus is being made through the electronic system to focus on senior citizens abusing, say, opiates and then end up getting opiates with fentanyl in it? That's number one question I have. Number two, as a judge, I have sentenced doctors to prison for prescription with undercover agents. I haven't had a chance to look at Trump's detailed proposal, but are we going to increase surveillance officers rather than just rely on the electronic system? Those are the two questions I have of you.
You want to start? Okay. All right. You see this is going on. So, General.
I think the first question was sort of the tracking of the use of opioids in senior citizens and sort of the kind of. Through your drug court, yeah.
I could just make one comment. I believe in the Christie Commission report, or it might have been actually just CMS announcement the other day, there's going to be some specific grant funding for innovation grants that could also look at opioid abuse issues with seniors. So I think that's an approach, and obviously CMS can help lead the way on that. I'd probably turn to my long-term, care colleagues for more comments on that. But I know that's been more of a focus of CMS and HHS.
I would say, again, eligibility systems that allow you to stratify a population and then look at who the most susceptible users are, be they the elderly or anyone else, are certainly very, very capable today. And the system that we are leveraging and talking about to a number of folks across the healthcare industry certainly get into that degree of stratification to identify those that are most at risk for opioid addiction.
Thank you. Thank you, Judge, for your work in starting the drug court. This is a great initiative.
Where we conducted basically what you call review hearings. And in one instance, the federal district judge gave me the authority to hold the mayor in contempt with reference to the agencies not providing the services a person needed. Several years ago, I met a gentleman who had been in and out of prison with heroin problems who came before me, and over 3 or 4 months, I held bi-weekly hearings and so forth. He told me he had been drug-free 31 years. And today, that particular day in July, when I was speaking to a youth group here on 4th of July weekend, he said, I've been drug-free, and today I'm a supervisor of breaking up drug gangs. So barring from the family law, and barring the issue of finding out what in a person is, and motivation, and I've had addicts say, Judge Burnett, I cannot let you down. And they've recovered. Some have been drug addicts and end up as legal secretaries in law firms. So, and indeed, I served on the competency committee for the national to make sure they didn't cherry pick people who obviously be successful. Let's deal with people who most are in need of the monitoring, the reinforcement, and you'd be surprised what you can accomplish.
Beautiful, beautiful. Thank you. Yes, sir.
I'm glad he spoke about the emotional welfare of a person, because there are a group of people that we have yet to discuss who are homeless. And there are a lot of shelters in the District of Columbia. And within those shelters, there are a lot of people who use prescription narcotics. But here's the problem for those people that work in those particular places. And I want to know, because I know that there are HIPAA laws in place. But what I want to know is, the next time you meet, are you going to include Catholic Charities, Coalition of the Homeless, those people who are handicapped by the HIPAA laws because they can't ask the guys coming in for the drug, and so they can just keep it on them. They can sell it in the shelter. They can give it to somebody in the shelter. They can do all sorts of things in that community. And it puts workers there as well as security at risk. And I noticed that when we have these, this is the first time I've been to this particular kind of symposium, but I've yet to hear anybody specifically identify that community, because it is a community, and it's a big one, and it's at risk. So could somebody expound on that? do you all intend to include them, Judge, moving forward? Because I know that you know that's a big problem.
So in drug court, we actually have individual case management. What works for you may not work for you and may not work for you. And what does that mean? We meet everyone where they are. For me to come in and say, you have a drug problem, let me see what I can do for you is not sufficient. Do you deal with homelessness? And if so, my case manager refers you to all the agencies that deal with your homelessness situation, contact the government. Do you have an ID? I've probably had to get quite a few of the clients who lack basic ID. The ID all of you have in your pockets right now? A lot of the clients do not have that.
That's right.
Sometimes one of the clients, he couldn't read. And so for our program, you have to have a GED or work and be productive. And we enrolled him in GED classes. So yes, I deal with the police. I work with the police and probation and social workers and things of that sort. But we also deal with the transitional housing, if that's what you need. The treatment programs. Religion is a big part of what we're talking about here. Some of the clientele do not like certain programs because of their religious leanings, and they would prefer a non-religious program. So we try to deal with all of it in the best way we can, but to simply say it's a lot. But we try to meet them where they are and figure out what they need. A lot of people think they know what they need. In reality, they may not know what's best for them.
Exactly.
So therein lies a lot of the tensions that occur in my daily situation. He will look me in the eye and say, all I need is my Suboxone. I know he needs actual treatment. I don't consider Suboxone only treatment. It's not.
Right.
It's a temporary fix for an actual real long-term problem that you're having. So we do deal with homelessness, education, religion, mental health. When you have people with dual diagnoses, some believe it could be drug-induced if you believe there's drug-induced mental health or not. So now I have to send you to mental health providers 2 days a week. I have to send you to drug treatment providers 2 days a week. I need to send you to educational classes 1 day a week. And you have to see me 1 day a week. We're running out of days. So a lot of the clients will say, you know what, I'd rather sit in jail and watch my cable TV versus have to go through all of that. I need people who want to be in drug court. I look for people who, that's the first, hi, my name is Joe, and I want to be in drug court. That's probably day one. And then we figure out what we need. We assess you through the social workers and what do you actually need. How long have you been? What is your drug of choice? What programs are available? If you have an opioid addiction, versus marijuana versus crack, we have different programs that may be right for you. Or if you're a young man who needs leadership in your life and goals and workforce training development, we have other programs for that. So a lot of programs out there, but we probably need about 8 times the number of programs we currently have.
Yeah, that's why I asked that question, because I was ready to ask the FBI agent up there, like I was telling a friend of mine, I think it's this month, all the shelters meet and they discuss hypothermia. And the reason I mention it, because it may be a good time for the police department or the FBI agencies to reach out to these various agencies so you can go in and sit in on some of their meetings and discuss what they can do to help you, so, you know, we can help each other with that. Because they work with these guys every day, and they can readily identify who's who and who doing what. Because there are a lot of people in there, like he just said, don't know they need help and might have to be given a push. So if they know that they have your assistance, you know, it might be a little better. What you think?
Sure, I'd like to respond. I appreciate your comments, and I always enjoy coming to symposiums like this because I believe I learn more than I offer, so I appreciate your comments. I have supported the U.S. Attorney's Office in D.C., and when they've done some education and awareness work in the homeless shelters, and I think that's a starting point, but you know, learning about some of the struggles that might be going on is going to be helpful as well. I have worked cases where you know, the film that we produced, the young lady in it that had passed away, Sierra, the drugs that led to her death came from someone who was homeless that, was supporting the situation, his addiction, through a sale of Medicaid-funded prescription pills. So it's a real problem. I appreciate the input.
Thank you for your comments, and so noted your suggestion about making sure that we have that angle covered if Howard University does this again. So thank you very much for your comment. Yes, ma'am.
Hi, everyone. My name is Maymuna Trayor. I'm a senior biology major here at Howard. Here at Howard University. Good. And an aspiring clinician. So basically, we've really been talking about like this interdisciplinary approach. So one of the things I've been thinking about is, do you all have a system in place that basically looks at how different demographics, like the reasons why different demographics start using opioids? So for example, you say you were having like these tracking systems. If you were to follow the different districts, the different counties, and look at what demographics are mostly going for these opioids, and then you were saying that you have these 3 common reasons why you think that people go for them. So if you could combine that and then target these areas to try to like help these demographics. I have an example. So I went to a predominantly white high school, and I would say around 14, 15, that's when our class really started engaging in like drugs that were like cocaine and stuff like that. And you would think, why would they need that considering they're coming from these very prominent families where they have everything? And my reason for being is I think they were having that void that you were talking about, that's something that they couldn't fulfill because they had everything. So if we had started programs in our school early that could attack those things, we could have avoided that. So I guess my central question is, what do you believe you all can do to target these demographics and link with different organizations to stop them from using opioids before they even get there? Thank you.
Great question, and the answer is very innocuous. Early intervention is critical. So we talk about the void, the hurt, the hang-ups, what people do to fill up that hole. The way it's been explained to me is people try to address that hole either through healthy means or unhealthy means. So when someone starts turning to, alcohol, or maybe overworking, or bad images on the internet, and they start down that path, if that path is not disrupted before they hit the opiate, there's big trouble. So, that early intervention point is key. Perhaps working with school systems and that education component within the schools at all ages is critical. But the teachers, the administrators, the nurses, the counselors, making sure that they know the warning signs to look out for, and the resources that we talk about putting together, they need to be part of that and be part of the discussion so that they're aware how to get people or young people into those resources and effect an early intervention.
So I'm going to ask you to meet with the panelists that didn't offer you an opinion afterwards. And we're going to take 2 more questions, and then we're going to wrap up this session. But so you can nail them after this is over with, and make sure that everyone gives you their point of view. How's that? But thank you for a great question. Yes, sir.
I'm Dr. Edwin Chapman. This has just been a wealth of information. I'd like to meet this young lady also because she just nailed it. Howard University, the Howard University Human Genome Center and the School of Pharmacy are now working with NIH identifying genetic markers. If you want to look up Dr. Kenneth Blum, who described about 20 years ago reward deficiency syndrome, which means that we're born with different alleles, so that there's a propensity among about 1/3 of the population in this country for any kind of addiction, whether it's alcohol, drugs, gambling, sex, etc. And so, but it's very complex and it's polymorphic, so you have to really do a genetic profile. So that's one of the things that my office is doing through Howard University, the School of Pharmacy, and the Genome Center to identify that. The second thing is I'm very intrigued by Eagle Force and the data that they have because my electronic medical records in my office can pull up some prescriptions from some patients. It's not always up to date and accurate. But if we could pull in the kind of information in a nanosecond that he's talking about, you save so many steps. In other words, my secretary doesn't have to get on the phone and call 2 or 3 different places to gather information. It comes up in the record. So metformin comes up, amlodipine, other medications come up, but I don't know how long it takes that information to get there. But I think that big data that we're talking about is critical and could really close a number of gaps. And the third comment, we're missing a lot of low-hanging fruit. The District of Columbia, 98% of patients in the District of Columbia have insurance. So when that person overdoses, if he gets to the hospital and you collect that information, you can tie that information back to his insurance plan and contact him even if he won't stay in the hospital. The same thing if that patient happens to fall out on the street. One of my patients actually overdosed about 1.5 years ago under the building, and we went out. I thought he wasn't going to wake up. He got Narcan 3 times, came out, and got up and picked up his hat, grabbed his dogs, and walked off. But I knew who he was because I had his information in my telephone. I can pull up my record. But that patient, had we had his insurance information, even if he walked away, you could tie it back to the insurance plan. So that's how you get these patients to bring them into treatment. They might not go right away, but you can bring them in a day or 2, but you got to send somebody out to get them.
If I could, and your comment about a couple of years ago in a study, and I can't really recall exactly where the number came from, but over 279 million opioid prescriptions were prescribed across the United States. And so if you can leverage predictive analytic tools that you can then push that information to the prescriber in the electronic healthcare record system or the EMR, or at the pharmacy workstation. It's all about decreasing the amount of time that you have based upon the alerts that you receive to then make clear, informed decisions with respect to that particular prescription or that patient based upon their profile. The ability and the great thing about what I've learned in transition from being an operator on active duty into the world of science, math, technology, and engineering to sort of bring forth creative solutions that help reduce that time for prescribers and physicians or pharmacists to make critical decisions, because there are people that clearly need that pain medication. And then in some cases, there are going to be those that either addicted or are part of a pill mill and reselling these items. So the ability to then be able to see in real time, based upon individual patient profiles, and then build that capacity to then push it forward back into the EMR and to the pharmacy workstation are the things that we are working forward to try to help alleviate some of this problem.
Thank you for your question. You get the last question.
Last question. So I'll try to make it a good one that involves all of the panels. CMS for Medicare, Medicaid, over the last 3 years have only spent 8% of the dollars for pharmacy forget what they call it, MTM, Medication Therapy Management Systems. And I'm going to leverage off the young lady's questions. And I'm going to try to get you paid. The laws for medication therapy management, which is the ability for the pharmacist to talk to the patient, second most highest respected in the healthcare community, and get paid for that time. So when we look at monitoring on a prescription drug monitoring program, what we're really saying to the General's 275 million transactions is that pharmacist has to come out of their workflow, go to a separate system, spend 7 to 10 minutes to review that system, and then go back to their workflow, and the doctor has to do the same thing. So what we're really saying is we've got to do 15 minutes times 275 million. That's an additional workflow to the pharmacist and additional workflow to the doctor that's not been equated. So if we can do that, if we have to do that, if we could get the qualifying position, he's going to pay me after this, for the pharmacist to get paid on that MTM and get the medication therapy management function paid for, we have now empowered the largest volume. We've got them at the point of sale. And so the question then becomes, if we can alert to that and we can stratify those patients, that whole of government approach, the question would be, how do we incorporate that to empower the pharmacists, look at the stratification on all of the records that Dr. Chapman talked about, intervene earliest. It might be an email sending information on opioids if we see an alert. It may be 2 of those alerts bringing me back to the pharmacist trigger. It may be 3 of them that get the nurse to call. It may be 4 of them that get you back into the doctor, all before we get the arrest and the court. So that's the open-ended question for the panel.
I think we're going to ask Tom to comment on that.
I can start on that, and I think I just love to hear you talking about empowering the pharmacist, because that's what we're trying to do every day in the association and working with our colleagues. I think there's 2 things there, 2 places that we really focus on. One is try to get pharmacist provider status. That's a federal legislative effort. We've got a lot of support in the Senate, 46 members of the Senate, 200 and almost 30 members in the House, so we continue to push for that. So being able to do basic services here, the pharmacists, so they can perform up their license. So there's the political struggle on that we work on. On MTM, we've had not as much success in the program through CMS. Unfortunately, it's been part of, I think, reluctance from some of the plans to really embrace it. I think we have a misalignment of some of the incentives. I think it's pretty proven in the literature and the studies of the power of MTM to bring better medication adherence. What we're really looking at is this enhanced MTM model in CMS that's going on now. And that's, we're trying to make sure they're using enough community retail pharmacists. I mean, to me, that's obviously the best form, that person-on-person counseling to bring, be able to just bring medication reconciliation and assistance counseling. So I think there still has to be, we're going to see how that model proceeds. We're going to keep monitoring that, pushing CMS to do more. I think working with the plans, there's a number of, I don't want to get into, there's a lot of very weedy details here about different administrative ratios of how MTM's counted as plans count them, how it's specifically targeted. But the problem is right now in the MA programs and the Part D programs, we're still not getting the utilization. I think part of it is we have to show the worth in this enhanced MTM model and continue doing the good work you're doing. We're trying to put more money into studies to show the effectiveness of MTM. Because I think at the end of the day, you're right. You can't really have that conversation about empowering pharmacists to go out and really try to tackle this problem if you still have them doing everything you do in a pharmacy every day. And I think that's what we try to do every day, whether it's the technology, PDMPs, e-prescribing to make your job easier, but also working on those legislative push and those regulatory pushes to make sure you can really perform to the top of your license. I hope I answered your question. I'm trying.
Thank you. Please join me in thanking our panel.
Thank you so much to our panel. At this time, we wanted to do just a little bit of a recognition for one of our champions in the college and who is very passionate about policy development generally and the role of Howard given our proximity to the Hill. This is somebody that you're aware of, but she doesn't know I'm doing this. And we would like to honor Minnie Baylor Henry for her generosity in support of the college and just her big heart in making sure that these types of events go unhitched. We have a special presentation that we do for select individuals at the college, and this hasn't been done very frequently because it's only reserved for folks who have given above, $10,000 to the college. And Miss Baylor has actually given tens of thousands to the college in support of the work with a particular passion towards our policy symposium. So I want you to please rise and give a very, very, very strong congratulations to Miss Baylor Henry for her generosity towards the conference.